thank you so much to all of our panelists today. I think since everyone is here, we can go ahead and get started.
Yeah.
Let's just introduce everyone on the panel first. So John, would you mind? Oh, there we go. So first up, we have Dr. Guan. Dr. Guan was actually part of our panel last year, and we are so happy to invite him to come back this year. He did his medical school at University of Iowa and is currently did his residency at University of Iowa and then his VIR training at Hopkins, and now is part of the SIR Global IR Training Network Chair. And I'd love to learn more about the surveys and what you guys found out as we were talking earlier before today started. So we'll ask you for more questions about that later. Next up, we have Dr. Andrade. I'm super excited to invite Dr. Andrade. I actually met one of your trainees at RSNA. So she was the one who recommended that I invite you. So super happy that you're able to join us today. He is from Brazil and used to be the Sabris president. So we're super excited to have him here today as well. Next up, we have Dr. Kesselman, who is highly recommended by my mentor, Dr. Stewart. And he is currently at Stanford, and he is the Associate Director of IR, RADAID International in Nairobi. And he's did his training at New York Medical College, residency at SUNY Downstate, and his fellowship at Stanford. And then last but not least, we have Dr. Arai, and he is part of the Japan SIR version, and he did his training at, I cannot say that name, so I will not say it, at his residency at Tokyo Medical Center. He was the previous president at the Japanese SIR, and he was the founder of JIVR SOG and the current chief of International and Diagnostic Radiology in the National Cancer Center and the executive advisor to the president. We are super, super, super grateful to have this amazing group of panelists. We've worked hard to find the perfect amount of panelists to have, and I think my dream came true when everyone said yes. So we're super excited to have everyone here today. So I'll start with a brief introductory question. I know everyone comes from different countries, so I would just love to learn, what does a typical IR education timeline look like in your country? And I'll ask this to Dr. Andrade and then to Dr. Arai.
Well, good morning, everybody. It's a pleasure to be here. Thanks for the opportunity. Well, in Brazil, to become an IR, you have two ways. You can do vascular surgery and you can do radiology. It's a common pathway that then you need to do 2 years of full integrated interventional radiology training. So you can do in Brazil to become a radiologist, you just need 3 years of residence and then 2 more years of interventional radiology, and you become an interventional radiology in the let's say the fastest way in 5 years after med school. If you go through the vascular surgery way, you're gonna need some more years because you need to do general surgery, then you have to do 2 years of vascular surgery, and then 2 years of interventional radiology. So that is the two ways that you can get to become an IR in Brazil.
That's amazing. Thank you, Dr. Andrade. And Dr. Arai, what about in Japan? Is it similar? Would love to hear more.
Thank you very much. And it's it's really at the midnight in Japan. And now that Japan is it's not easy to run and any kind of IR because some still the number of interventional radiologists not so many. So member of JSIR society is we have the over 2,000 members. However, the daily practices mainly not clearly and only focusing on the IR. So many IR doctors must perform not only IR, also they must perform some diagnostic works. So this is a big problem in Japan. And other factors, and Japanese insurance system is very different from other countries, overseas countries. So because of that, and some IRs, for example, so Y90 and also the TIPS is still not approved in Japan. So of course, some treatment of IR for the liver tumors is very active. We perform that. However, some devices such as the TIPS and the Y90 is not, we cannot use now. So this is big problem. However, we always very welcome to the foreigner, the younger intervention radiologists come to Japan, and sometimes we perform the training and perform the IRs together. So if you have the chance, please come to Japan. So we have so many cases, especially the vascular disease and liver tumor disease. Thank you.
And Dr. Kesselman, I know you're helping to build out some programs in Kenya. What does the training structure look like in Kenya right now?
Yeah, so yeah, we work in Kenya, and then Radi's a large nonprofit, so we do IR work in other countries as well. I've seen all kinds of different training schemes, particularly for IR, based on whether they integrate it early or late. For Kenya in specific, we started in conjunction with the staff there and built out a fellowship and curriculum that started in I want to say 2019. The way we built it out is it's a 2-year program after a residency. So they do 2 years, 2 fellows a year. And part of that also involves an observership here in the US for a month as well. So that's kind of how it's been built. They have different levels that they have to do in terms of their examinations, which is based more on the university level at the University of Nairobi, but their final exams will come at the end of the 2-year track.
And then can they do any sort of residency prior to that, or is it specifically a surgery or a radiology, like, I don't want to say residency, but pathway that they have before they start the fellowship?
That's a great question. It's very similar to what I've seen in other countries, both in developing Africa and also in Asia. But no, they can't go straight. So the way it works is actually when they finish medical school, they come out and they're a generalist, and they have to go back to their home city or their home province that they're in. They work there for a period, I think, of 1 to 3 years, and then they can then apply, and the government will fund them to do a residency in something specific like radiology. And then after that, they can go in and do their fellowship after finishing their training. If the negative to that is that they forego, being able to earn as an attending when they come out as a radiologist. So they have additional training for 2 years where they wouldn't be funded that way.
Sounds good. Thank you so much. So my question to everyone would be, what does a typical VIR attending do on a day-to-day basis? Do you follow patients before and after the procedure? Do you have clinic that you see patients at? Would love to learn a little bit more. And we'll go in reverse this time. So Dr. Kesselman, if you want to talk about your experience in the African countries, and then we'll go to Dr. Arai.
Yeah, no problem. Actually, next year might be good. We could bring on one of our graduate trainees from Kenya to talk a little bit more, because I feel like I'm talking about their experience. But in terms of their clinical experience, I think it's very good. We built it out very comparable to what we have here, at least at the institutions I've worked at Cornell and Stanford. So they do have an admitting service. They do have a floor that they used to manage. I think now it's shared with medicine, but they do round on patients every day, especially the ones that stay after. Their patients travel very far for their procedures. So often they stay after for a certain period of time before traveling back to their province, which could be like very, very many hours of travel. And then they have a clinic. It's much busier than any clinic I've seen. Each trainee is seeing something like 30 to 40 patients in a clinic, which I thought was, a very large amount for them to see in a specific, in a single clinic. So, the clinic is supervised by one of the local IRs, or when we do deployments, one of our team as well, join them as well. Yep.
What about Dr. Arai? What has your experience been?
Sorry, that's so sorry. What?
Yeah, so our question was, what does a typical VIR attending do? Do you follow patients before and after procedures? Do you have a clinical element that's incorporated into it, or is it just purely the procedural aspect of doing the not the tips, whatever procedure it is?
Of course, and we are fully care of the patient the day they receive the IR. So we have in Japan we have very good communication with other specialties and internal medicine or the surgeons. So because of that, then this is not so big problem. However, now maybe you have the very focusing on the cutting edge. Maybe you have much interest in the cutting-edge new IRs or very common, very special procedures. However, please look at the overall world. The Japan is now the very top aging country. There is so many aged patients. So usually we think the IR is very special treatment for the not aged people. However, aged people have many kinds of such as cardiac disease and vascular disease and others. However, they are sometimes out of indication patient. However, in future, we intervention radiologists must focusing on how to perform our IR to the elderly peoples. So, and not still in Japan, not so common. However, I think in very near future, so-called the geriatric IR and the IR for the old patient is a very big field and very important field in the world, not only Japan.
Yeah, so a lot of your attendings, they're just doing procedures every day for the patients that come. Okay.
Yeah.
And do they also read as well on the side? I know you were talking about how a lot of them are diagnostic radiology trained. Do they also, because I know it's very common here in the US where some of the doctors will read twice a week and then the rest of the week they might do procedures. Is that also very common in Japan as well?
Yeah, yes.
Okay, thank you so much. And then Dr. Andrade, if you would like to expand on Brazil as well.
Yeah, no, I really, Dr. Charles' daughter said 60 years ago that the IR needs to have to take care of the patients or it will become just a high-skill plumber. He said that 60 years ago, and it's still completely truth. So I really believe that doing clinic, see the patient before and after are mandatory. We have to do that, or you're gonna become high-skilled plumbers or technicians. Okay, so I really believe that we need to be involved with the whole patient care. And I can tell about a little bit about the Brazilian IR. I started IR in 2001, so 23 years ago, and in this time in Brazil, we was we was doing everything. We was doing neurointerventional radiology, was doing peripheral vascular percutaneous, everything, and then it starts to divide. Then neuroradiology becomes a different specialty. But even now, IR is getting splitted, and you have some people doing just interventional oncology, others doing only endovascular interventions. So what I really believe for the radiologist that is in training, you have to see everything. You have to be exposed to everything. You cannot choose early what you want to do because you don't know the future. We don't know the future. I'm a proof of it. I did a lot of things, and now I just moved to US, and I'm doing different things that I was used to do. So take your time, be exposed to all the clinics, everything you can, especially for the radiologists that during the radiology residence, we are not trained for clinical skills and clinics and things like that. So try to fill this gap on the IR training. Sometimes you can think it's boring, but it's very important. So get exposed to everything. Don't choose a specific area of IR too early. It can be not good for you in the future.
Thank you for that advice for all the trainees that are on this call right now. Dr. Guan, I guess now that we've heard a little bit about these different experiences, I'd love to learn more about what you've learned from your position as the Global Trainee Network Chair at SIR. What have you noticed are the trends with a lot of the international students that are coming to the US and incorporating within our system here?
Yeah, thanks, Abiana. This is a very nice conversation. I would say, so first, I guess for my position at Cleveland Clinic, I've been working there 3 years now, started right after fellowship. In clinic, at the clinic, we do have clinic visits that we as attendings attend. A lot of it is have APP involvement, like they help with follow-ups on patients. I personally kind of focus on a few things, like I do cholangioscopy procedures. I do a lot of embolization, so prostates, UFEs, and now I'm starting oncology treatments too, so Y90s and TACEs as well. We have specialty clinics depending on the kind of disease process. So if patients come in with, we have tumor board meetings to discuss HCC patients or metastatic colorectal cancer patients and liver. We also have like a multidisciplinary liver clinic that's run by IRs, surgeons, medical oncologists, radiation oncologists. We kind of all see the patients together. So depending on the kind of disease, and there's like also IVC filter clinics, depending on the kind of disease, they kind of are seen in a different clinic. And then, once we decide, this patient is good for IR procedure, like a local regional therapy, for instance, then we get scheduled with us for procedure. For prostates, I have the patients see me in IR clinic first, do the procedure, and I do follow them up, as the usual published schedules, like 1 month, 3 months, 6 months. So we definitely have longitudinal follow-up. I think the one thing at the clinic is because things tend to get so busy, it's hard for the attending to be present at every single visit. So I try to talk to the patients at the initial consults, but then a lot of the follow-ups, unless there's something that I want to specifically talk to the patients about, they're kind of like seen by APPs. Now, from my experience on the global fronts, we actually just finished this survey project that we're trying to get published in the next few months here. We sent the survey out to the different societies to understand practice patterns, the kind of procedures that are done, whether IR training is available, exposure is available, and what the questions like what are the most difficult challenges that you have in their region. And of course, just like in the US, depending on the hospital, it's different. It's kind of hard to generalize, in this continent, this is how things are done, because every country, I'm sure, is different. Within the country, every hospital is different. In general, I think it seems that, almost 30% of the training programs, and I'm just going off the top of my head because I don't remember the exact number, but it's like up to 30% of the radiology trainees don't get any IR exposure. And a lot of places, like what Dr. Arai said, the radiologists are expected to do diagnostic and IR work. A lot of it's more, kind of like basic level IRs, like ablations, biopsies. Some countries don't really have any IR exposure in their residency. Like I also have this digestive disease interventions issue coming out, where a couple of the manuscripts I asked attendings from Indonesia and Vietnam to write about the IR training and IR practices there. I think in Vietnam, there's only maybe one program, one hospital that had enough IR cases to have IR training established, and something very similar in Indonesia. So I think, yes, whereas in East Europe, Korea, Japan, I think IR is very established. In a lot of other countries, it may not be. And a lot of it really depends on how IR is recognized, whether patients even know about the procedure, which goes, I guess it leads me to another topic we can talk about later. But, there recently, I think Dr. Macri and Jeff Chick came out with a survey in the US about IR practice itself. And I think most patients in the US even still don't know what interventional radiology is and what procedures we do, even though most patients would say if they knew this occurred, they would prefer a minimally invasive procedure rather than surgery for things that they've been treated for. So yeah. Whirlwind response. I think it's a lot of things we can talk about potentially.
Yeah, thank you so much for sharing. I did have a question for Dr. Arai. So I was very fortunate to go to CIRSE last year, and I noticed that a lot of research is happening, especially in like Japan and Korea. What is the process of going about research, and why is, I guess, Japan and Korea such like a wealth of like new randomized control trials, especially I know in the interventional oncology space as well?
Thank you very much. Of course, also in Japan and Korea, and doing the clinical trial, especially the randomized control trials, it was not so easy. So our studies, some randomized control trial was failed, stopped because we cannot enroll enough number of patients. However, in Japan, the key point is IR is, I suppose, not well recognized by, especially by the medical oncologist. So if we can get our IR confirmed field, we must show evidence. This is our key power. So because of that, then we started nearly 2003. So nearly 20 years ago, we started the clinical trial group, and some studies we performed joining with Korea and perform clinical trials. So this is a very important process. So getting the recognition from the other specialties. So however, it is a step by step, and still also in Japan now doing the clinical trial is not so easy. So because it does some Japanese law, it's very strict. So number of ongoing studies decreasing now. So now that we performed the over 30 clinical trials, however, ongoing trials only now 4 or 5 around that. So not only Japan, and of course, the other countries, and especially the Asian countries, we must perform some clinical trials. However, if we can show some very clear evidences, the evidence is common information for any country. So if the very strong evidence coming from the United States, coming from Japan, coming from China or Korea, it's okay. It's based on these evidences we can use. It makes our platform. So of course. So please, I want to say, please don't wait for the evidence coming. Please make evidence by yourself. I hope it.
Thank you so much for sharing. I was just amazed by all the Cersei has that area where you talk about the late breaking trials that are happening, and
Right.
everyone that I want probably from an Asian country. So thank you so much for sharing. Dr. Kesselman, I had a question for you. Thank you so much for coming today. So I know that you've done a lot with RAD Aid. What would you say is one of the major barriers or threats to IR, especially in a lot of the African countries?
Sorry about that. I got cut off. They're doing construction here and the power went out there for briefly. But I'm glad I was able to log back on. In terms of threats at least in the countries that we work in, particularly in the fellowship in Nairobi, I think other specialties are getting involved in image-guided procedures and interventions, endovascular interventions. So there's definitely that competition that we saw early on here in IR, but thankfully, starting a fellowship fresh, they built in those clinical aspects that I think are important that help them compete. And then I think costs are a big issue. For them, the supplies, the consumables are very hard to get a hold of because shipping logistics, in-country policies, all these things make it very difficult to get certain supplies that are needed for procedures. So it really limits what they can do in terms of being able to offer everything that we offer here, the full complement that we offer here in the US. They're definitely working on it. I think there's definitely a lot of progress that's been made, particularly in the places we work, but it's definitely a different kind of challenge that we face here, I think, for those kind of aspects.
And then I guess a follow-up question, have you noticed anything in terms of the trainee environment that has helped to grow IR more in these countries, like something that you've implemented or any initiatives that have been very successful?
Yeah, I think in terms of training, one of the greatest initiatives we did was the simulation training that we kind of implemented early on. So we do endovascular simulation as part of our curriculum, actually, at the training program in Nairobi. And it's been extremely helpful, mainly for the reason that I mentioned before, with a lack of consumables and a lack of supplies, it limits the amount of procedures they can do outside of emergencies and things like that, especially like complex endovascular procedures. So if they're able to practice on a simulator beforehand and do those endovascular procedures on a pretty realistic simulator like the Mentis that we have, then it makes them more prepared when they do the actual case, and they can be selective and use less of the product and really pick their case as well. So that's kind of one of the big things that we implemented early on that was, I think, very successful. Also increasing awareness. So we let them know multidisciplinary meetings and things like that with other divisions within the hospital is very important to be established. They run tumor boards. They have other multi-Ds, and I think that helps spread the awareness of IR in their institutions, and I think that's extremely helpful too.
Yes, Dr. Andrade, you have your hand up.
Oh yeah, just to talk about the IR recognition, I guess it's a worldwide problem, worldwide issue. It's not different in any country, even here in US. You have a lot of patients or even physicians that don't know the specialty and what we can offer. But I really agree with Dr. Arai that we have to be proactive. We have to go and try to go further. I mean, the oncology patient, one of the first approach, one of the first contact in the hospital is with us, is to do the biopsy, ultrasound or CT guided biopsy, is to put the port cat that he's gonna use for long-term chemotherapy. So do we talk with our patients when we are doing a biopsy and say, we are in interventional radiology, we can do a lot of things. Have you ever heard about interventional radiology? Do you know that we can treat some kind of tumors? And just to introduce him the specialty, probably he will go to look for some information on Google or everywhere, anywhere. And they're gonna see that we can put a needle and burn the tumor, and they're gonna ask his oncologist about this kind of treatment. So I really believe we need to be proactive. Sometimes we want the results to come, but we don't go forward looking for them. So I really believe that we need to spend 2 or 3 minutes in each patient that is being diagnosed with cancer, that there is a specialty that we can do minimally invasive treatment, use a lot of technology, be very precise, a lot of amazing things, and just do a brainstorm, and then he's gonna spread this to the others.
Thank you so much for sharing, Dr. Andrade. I feel like that's a thought that a lot of us trainees have and are actively working on here in the US. Dr. Kesselman, I believe that Dr. Guan has a question for you in the chat if you want to go ahead and answer his question. But I do have a question for Dr. Andrade. So I know that you were in Brazil and now you're here in the US. It's very rare that we get someone that has visited and has 2 very different experiences. What would you say is like one of the major differences that you've noticed that we do here in the US, for better or for worse, that might have been a little bit of a transition for you compared to your experience back in Brazil?
Yeah, I'm yet on the transition. I'm here for just 5 months, so it's not a complete transition yet. But I can assure that it's 2 completely different realities. Even in Brazil, we have 2 completely different realities. We have the public insurance that is hard. You have to be very creative and try to do a lot of things without device and without structures, the very simple facilities. In the private insurance in Brazil is almost the same of here in US. You have nice facilities. You have almost all device that you can use. So but the laws are not so strict, so you can be a little more creative and trying to develop something different. You are more free, let's say. But I'm really enjoying here in Brazil. We were working in a group with vascular surgeons and IRs. So we had a different kind of approach. We do a lot of vascular procedures. And here we at least on the university I'm working, we are more really IRs. The vascular procedures are done by the vascular surgeons. So it's quite different, but it's a very, that's why I say during your treatment, try to do everything, try to learn everything. You don't know your future. You need to be at least have a solid base for any area of IR, because you can need to change, you can need to reinvent yourself, and you need to have solid base. But what I would like to say is here for sure we are much more recognized than in Brazil. In Brazil, the Brazilian society, we have about 400 IRs for the whole country. It's Brazil is not as big as the US, but it's a big country. So 400 IRs is a very few people. We are not so recognized as here. And we have a lot of economic issues and public, especially in public insurance, that is it's much higher to develop the IR. But the private practice is quite similar here. We have a lot of nice IRs, very nice device development, trials, and everything ongoing. So it's two different realities, but we have in Brazil about 10% of the population that has almost the same reality of US. That, just to give you an idea, 8, not 80, just 8% of the population in Brazil has private insurance.
Thank you for sharing, Dr. Andrade. So I have a question for you that I asked earlier, but to Dr. Arai. What do you believe is the biggest threat to IR in Japan and with the Japan SIR?
Thank you. Of course, now in Japan, maybe the Japanese IR is IR for the liver tumors. However, the reality is we have any kind of IRs, so all kind of IRs. So however, there is some questions in the chat, and I fully agree with the problem is awareness of IR, awareness of the recognition of IR. So also in Japan, maybe you understand the IR is very common in Japan. However, it's not true. In Japan, most of physicians, they do not know IR. So this is a big problem. And also so we discussed that in such as the international conference, each country's IR is very different because of its economical backgrounds. In Asian countries, the United States, the India, China, European countries, it's quite different, especially the equipment, because usually the IR equipment is not so cheap. So I have no clear answer. However, our main problem, and we break through the big problem, is how to educate, how to know, inform IR to the not only physicians of the public and also physicians. So because of that, and in Japan, we have the many kinds of IRs, and almost all kinds of IR we perform. However, still also in Japan, it is not well recognized in the medical field. It's true. And
Is there,
sorry,
I guess, a follow-up question? Go ahead.
So how about the recognition of the awareness of IR in United States? Very well known.
Yeah, so I think if I remember correctly, that survey that was published, it was actually published in JVIR last year that came out. they said that I think it was like 92% of patients, when given the options of, once they were told, IR can perform this procedure versus surgery, which one would you prefer? 92% said they prefer IR procedures. But then when they asked how many people knew what IR is and the procedures that IR offered, it was more than like 50% of the patients did not know what IR was and what it offered. So there was a huge discrepancy about what is available and what patients actually want. And that's true also for primary care, like the referrers. The physicians a lot of times didn't know what IR offered as well. So very similar problem.
Yeah. Thank you.
Is there anything, I guess I can open this to all the panelists here. Is there anything that your country is doing to bring more awareness to IR? It seems like a recurring theme. So any initiatives that have been successful that you want to share?
Yeah, I can share. In Brazil, we started 2 years ago annual meeting. It's online, so it's an annual meeting for medical students, just about IR. It's usually we take 1 month, and each Wednesday of this month we discuss an issue. The first one, percutaneous. So we discuss a lot. Of course, it's just to show the techniques, just to show what IR can offer. Our goal is not to make every student become an IR, but it's trying to show them what IR is, so the future gynecologist or the future urologist have an idea what IR is. So we are doing that for 2 years, and we published a book for IR for medical students. So it's the idea to spread, to take the base of the, it's impossible to try. Some people say, no, let's do some marketing and show what IR is for the whole population. I don't think it's easy. It's very difficult, but of course you can use social media and networks to try to do that, but it's not easy. I really believe we need to do the next step is to show all the physicians. We need to, even the physicians they don't know what is IR. It's impossible to get the whole population. So our idea in Brazil has been to show for all medical students what is IR, because more than 90% of the universities in Brazil, they are not exposed to even one lecture of IR during their med school.
Yeah, personally, I actually did not know what IR was until my last year of medical school. And it actually did affect, my residency applications once I was able to scrub in for an IR procedure. So I think early exposure to medical students, especially about what IR is very important. And I think a lot of med students who did not express interest in radiology, a lot of them just, go through training not knowing what we can offer.
Sorry, go ahead.
No, just to know if there is a US course for med students about IR, introduction to IR, is it?
At least when I went through med school, there wasn't. There were lectures on different surgical subspecialties. Like I remember there was like urodynamic study lecture given. There was different talks from orthopedics. There was one radiology lecture. Actually, there is like a radiology lecture on each organ pathology. Like when we went through the lung systems, there was a chest radiologist that came, talked about chest findings on chest x-rays and so forth, or belly and brain. But no, there was no lecture I recall about interventional radiology.
Yeah, I think it's institution specific though, because at our institution, yearly I give a talk to the medical students. I think the MS1s and 2s on an intro to IR. So I think it's specific as part of like the radiology elective that they have. So, so yeah, I guess it varies by institution, but some have early exposure, some don't. But I think it's getting better from what I see, especially doing some of the interviews we see. A a lot of them learn about it earlier and earlier, which is great.
Yeah, I think I need to request that for Case Western Cleveland Clinic med students here.
I will say, as like a medical student myself, a lot of it is that we are building like the SIR Medical Student Council network that has also helped to find people who are going through the application cycle, who are older and maybe have a little bit more experience, who can talk about what they've done with an IR that I think is helping to build the application pool as well. But personally, for my institution at UCLA, we don't necessarily have a system inbuilt, but we do have access to attendings if we see them, or if I'm on my internal medicine rotation and my patient has an IR procedure, I'm allowed to go and watch the IR procedure. So I think that's been a primary way that a lot of people are getting exposure, as well as that the patient that they're taking care of needs IR for something and they're like, oh, I don't know what IR is. Let me go and see what they're doing. And I think that's also helping with some of the exposure as well.
Yeah, no, that's great. I think that's oh, sorry, I don't want to interrupt, but I think that's a great way to get exposure as well, because I think we're involved in the care early on. So I think that's great. And then Dr. Vattencherry is mentioning a lot in the chat, which I think is important. Even at my institution where IR is really well known, as we build out new service lines and things expand, we're constantly giving out, talks to the other surgical services, other medical services, and those outreach talks I think are very important to establish those relationships, even, different ways to collaborate with other services. So I think even if you do establish, it's a continuing process to continue to do that outreach.
And then I know Dr. Guan had a handful of questions in the chat, so feel free to ask your questions, Dr. Guan, verbally as well.
Oh, no, I just want to echo what Andrew just said. For prostates, I'm trying to build lectures to give out to like family care urology, especially like when we're trying to start like new research projects to talk to radiation oncologists, things about what we can offer. I think it's very important.
So I know we've talked a lot about like awareness of IR with medical students, but what is like your, I guess, relationship with other specialties? I know that here we have a lot of discussion with like vascular surgery, for example, does certain procedures in certain hospitals. I would love to learn about the other countries. What is your relationship with the other specialties that might take care of similar disease processes?
I'm especially curious about Brazil, since vascular surgeons can become IRs, it sounds like.
Yeah. It used to be a very conflictual relation because the vascular surgeons started doing a lot of procedures, especially endovascular. But then we had an agreement that who wants to be an IR can be an IR, but needs to do a 2-year complete full 2-year training. So we are now in peace, and our meetings and everything, one supports the other. But it used to be a very conflictual relations for more than 10 years until the IR became a recognized specialty, and we have everything. The laws are all clear that if you are a vascular surgeon, you can do it, but you need to train for 2 years, because they use it to do vascular surgeon and do some fellows of 6 months or 1 year, and say that there was a IR. So for the last 10 years, it's solved. Everybody who wants to be an IR, even coming from the vascular surgery can become, but you have to do the 2 years and then has to apply for the SOBRIS, that is the Brazilian society. So he apply and then he becomes an IR. So now we are in peaceful, and after that, it's incredible how both societies are growing much more. Instead of keep fighting, now we are growing together. And our meeting that used to be 400 to 500 people now is over 1,000. So I really don't think that never the fights is the best solution. You need to find a way to solve it. And finally, we found in Brazil. We have no big deals with vascular surgeons anymore. Now we are together, and with other specialties. Oncology, we are very well recognized with oncologists. Urologists, not so well. The prostate embolization, just as Guan said, are not accepted for 80%, I would say 80 to 90% of the urologists. We don't need to be accepted by everyone, by everybody. We need to find, at least in my experience, you need to find 2 or 3 nice urologists that want to work together, and you can show your work. But as as an overall, as an average, we are very among the specialties, we are very well recognized. They see IR as a partner, and usually needed in the high complexity hospitals. Now we are being needed in moderate complex hospitals because we can do a lot of things in a faster, easier, and safest way. So IR is growing a lot and getting and spreading it. In Brazil, we have a very nice relationship with almost all the specialties.
And at the clinic here, I would say that there's a very close relationship between vascular surgery and IR. Granted, vascular surgery, I think, does pretty much all the PAD work, but I don't think there's like a strict policy like, hey, vascular surgery has to do these, IR has to do these. It's really who the services refer the patients to. And, one way we're trying to increase our service line, whenever we get, referrals or consults about, vessel lesions, or like acute things like a pseudoaneurysm in the iliacs, or, we want to place a stent graft. We don't want to be pushing those cases off. If we can do it, then we'll definitely do it on our end. I've gotten some requests for mesenteric ischemia treatments. So those we are seeing, and I think as we see more and more, accept more of those referrals, those referring teams will understand, IR do these as well, so we can get more of that. For dialysis patients, here at the clinic, both vascular surgery and IR can do fistula maintenance work and TDC placements. A lot of times we do, vascular surgery will reach out to us, hey, we can't add these patients to our schedule. Can you guys help out? And we definitely help out. I think we probably do most of the vast majority of the TDC placements and most fistula work. But yeah, again, we kind of do share those patients to some degree.
And then go ahead, Dr. Arai. You're muted.
Good communication between the IRO doctors and the other specialties, and the urologist and gynecologist and medical oncologist is of course very important. However, I suppose the very strongest way is for the good awareness of IR, it puts the IR on the guideline, each country's guideline or international guidelines. We need it puts the IR on the guideline. We must need evidences. So because of that, and I believe that performing clinical trials and make the evidence is very, very important. And it's of course the not easy way, the long way. However, maybe this is the strongest method to get the good awareness of IR and also the good new IR doctors.
And then because we're already talking, Dr. I would love to learn more about JIVROSG that you helped found, the process of founding this organization, and how you think it has changed the way that IRs are respected, especially in oncology. I know we talked a little bit about clinical trials, but we just love to learn more about your experience, and also any sort of research fellowships and stuff that you might offer for some of the trainees on this call as well.
Yeah, thank you very much. And of course, at the start of nearly 20 years ago, our study group is funded by the government. And however, now the situation is what changed. We cannot, it's not so easy to get money, financial support for the performing clinical trials. However, other side, and we also started. So at the beginning time, in our communities, there is very small number of doctors. They have the knowledge of how to perform clinical trials. So at first, it's very hard to educate, to learn what is clinical trials, what is evidence, what is how to make the evidences. However, now we have many IR doctors. They have some many experiences to make the protocol and clinical trials and perform the clinical trials. So we have we have in Japan, we have small seminars in the 2 or 3 times a year, seminar to what is a clinical trial, how to perform clinical trials. This seminar is for young interventional radiologists. So this is the very basic but very strong our background. So because of that, and in future, also in future, in Japan, we can, it is hopeful that we can perform the clinical trials. So now that we have the education system for young interventional radiologists about the clinical trial.
Thank you. I guess that leads into my last question for all the panelists today is what do you see as the future or the vision that you have for IR in your respective countries / society? And for Dr. Kesselman, that'll be for your initiatives with RadAid in Africa.
Sure. So in the future, I hope to see an expansion of the training programs that we've started. Right now, we currently have that one main fellowship in Nairobi that we're working on, and a few other in other countries. But it'd be nice to see one in more different settings and kind of mirror what we've been doing in Nairobi at all these other places. Because I think the way to really create sustainable programs is to focus on that training and provide that there, and then that'll build out the service lines in country as well. Really recruit the best candidates and get the programs running well, I think, and seeing more of that happen, I think, is what I hope to see in the future. Also, more interest definitely in the African continent, as well as the other places we work in terms of from device companies and suppliers so that they can get those consumables in country. And then to Dr. Arai's point, seeing more research coming out of these countries and even our own country help support us and get us in the guidelines, I think would be helpful.
Dr. Arai.
Yes, thank you very much. And so I agree. And the practical and frankly speaking, now that any countries, it's not so easy to getting the funding support from the government. So other side, and so the company's support is very strong. And so, however, sometimes the company's financial support leads sometimes long way to. So it's we must keep some very neutral position. And however, of course, and I can agree. So good use of financial support is our very important and it's right. It's good power to the right direction, correct direction.
And then Dr. Andrade.
Well, I really believe that the growth of IR in the last 20 years was, I would say, the childhood of the specialty. Now we are much more maturity with data, with acceptance of the other specialty. So I really see IR as amazing and one of the future specialty that we're gonna increase and grow and get each year more space. It's not a magic, just like it needs, each generation has to give one step further, and that's we, of course, we're gonna need a long way, as Dr. Arai said, but I can't imagine IR not being a very well known and a very nice, very, how can I say, a very aware specialty of the future. I have no doubt.
And then any parting thoughts, Dr. Guan?
Yeah, just going to echo everyone, what everyone said. I think IR is continuously developing since it was made its own specialty. I think more and more programs, and in the US, there's a lot of hospitals that are kind of leading the way for us. I know Dr. V at Kaiser, NCW, even my training at Hopkins, we have the inpatient consult service, making sure that we write, the recommendations in our notes, making sure that our opinions are fully evaluated. My hope is that at some point in the future, we'll have an equivalent representation in medical decision making compared to the services we offer, because right now there's a huge discrepancy. Making sure that patients do know our existence and they can make the decision as to they prefer minimally invasive procedures rather than surgery and choose their care. That would be great. But yeah, it's an ongoing battle, but I think we will get there. We just need to all work hard at it.
Yeah. Thank you so much for everyone for coming.